Okay, welcome to Spine Conference. Yeah, the screen's gone. They, I don't know why they took it away. So today's discussion will be post-laminectomy, iatrogenic spondylolisthesis with Parse fractures. And I'm going to record this and post it on the internet. So, as always. So I like case-based learning. This is the case. He's an 86-year-old man with left sciatica. And if you have any questions, just interrupt me. He's had the symptoms for a year and a half. He has pain down his left leg, nothing on the right, goes to his buttock, left anterior lateral thigh, left anterior lateral leg, left dorsum of his foot. Nothing on the right. He gets on his feet for 10 minutes and then he gets terrible pain. His pain is so bad that basically on the right, that's what he looks like when he walks. And it's very exhausting and very painful, and nothing is made to go away. I know, it looks terrible. I'll tell you what, if you just try walking like that for 5 minutes, it's exhausting. If you ever just don't imagine what his life is like. He had a previous L3 to L5 lumbar laminectomy in 2003, so 14 years ago. Other medical history: myasthenia gravis, which is mild, hypercholesterolemia, diabetes, bladder carcinoma treated with cystoscopy. On exam, he's 6 feet tall, 145 pounds, pretty thin man. And he has no significant deficits, no motor weakness, no significant sensory weakness. So any questions so far? Okay, so severe pain. And dermatomal distribution, anterior lateral thigh, lateral leg, lateral malleolus, dorsum of the foot. Aaron, what's that? L5, yeah. So basically the rule of thumb is lateral malleolus is always L5 for some reason. Medial malleolus is always L4. S1 is always the heel and the lateral border of the foot. L4 usually goes to the knee. L3 is the front of the thigh. So if you do spine surgery, you see, it's very simple. So these are the x-rays, Aaron. What do you show everybody what you see on the x-rays? Oops. So yeah, so 2 levels of spondylolisthesis. My former partner used to call it stair-step spondylolisthesis. Yeah, the discs have decreased at every single level. How about AP view? There's a scoliosis, right? So if you guys see the black are the pedicles, that left thing, the yellow thing, is the nerve root. And you can see if you have a curve, the concavity portion, the portion of the curve, you can see those 2 pedicles are coming towards each other, and you can compress the nerve root in the deformity. So a concave deformity causes the hole for the nerve or the foramen to become small. So that's something that should always be in your mind. Good morning. So flexion extension views, no real worsening of the spondylolisthesis. Okay, what do you see on Aaron? What do you see on the MRI? How about the foramen on the right? Don't poke my eye with that thing. Yeah. So show people the nerve root. See the nerve root and see the hole for the nerve root, which is the foramen. So this is the asymptomatic side. And personally, I think the best way to look at the foramen is parasagittal cut. So sagittal cut off the midline, that's the best way to see the foramen. The axial view, I feel, isn't as helpful. Okay, this is the symptomatic side, the left side. Show people the foramen. Yeah. So you see that there's basically no foramen for those nerve roots. The other thing is show people where the Parse fracture. Let me show you. It's right there. So you can see it, that black line that goes across the Parse area is basically the fracture, but it's very subtle on an MRI scan. Any questions about that so far? Okay, so this is an Axial View L5 S1. Show people the foramen, Aaron. Yeah, So the foramens look pretty normal there, centrally open. L4, L5, where the letters are, that's scar. And patients had a complete laminectomy at L4, L4. And just if you go just up a couple millimeters, this is the level of the foramen. But as you can see, it's not clear that there's femoral stenosis. Like you basically my opinion is on the axial cuts, it gives you maybe there's stenosis, but it's hard to know absolutely for sure that that foramen is open or closed. I mean, the parasagittal cut's much better, I think. And here's the next level up, L3, L4. And the foramen on the left is compressed and on the right it's not. But it's kind of a subtle view, you see that? And also the posterior spinous process is gone. Show everyone where the posterior spinous process used to be. Okay. So this is L2, L3, and this is sort of a normal-ish level. So see the foramens are open and centrally it's open, and he has a posterior spinous process. Okay, this is a level of the ilium, and I showed this just what's the white area, Aaron? Yeah, it's where we harvest the bone graft. So basically that white line is where I cut the top of the ilium, and then the middle part I scoop it out, and then you can see if I err medial, Aaron, show them the SI joint. If you err medial, you'll go into the SI joint, and you know you're in the SI joint because you pull out a piece of cartilage. You're like, oops, too medial. So you got to always point lateral. And then I fill that back up with allograft. So this is just one more thing. Is at L2, L3, he's stenotic there too. He has a disc herniation at L2, L3, and he has a facet cyst on the right. So his spinal canal is pretty tight there. Now this is a CAT scan, and it it shows that the Parse fracture doesn't even show up on the CAT scan that well. This is like a reconstruction CAT scan that I found. Okay, so just the problem is incapacitating sciatica, can't walk, severe pain, 2 levels of spondylolisthesis. He's had previous surgery, laminectomy. He's an octogenarian. He has some level of osteoporosis. He has no lumbar lordosis, lost lumbar lordosis. His foramen's tight. He has a Parse fracture. All right, what do we do for him? Aaron, just say no, sir. He saw another surgeon who said, I can't help you. Okay, so let's talk about laminectomy. So a full laminectomy is on the right top, a porthole's the bottom, and the unilateral laminectomy bilateral decompression is on the left. So a full laminectomy removes the posterior spinous process and removes the complete lamina. And those are other minimally invasive to do it. So this is a model. You can see that the lamina is totally removed. And Aaron, show them where the pars is. Yeah, so that you got to keep that intact, otherwise you can fracture it. You see how that can be a thin area. So that's one cartoon. But look at this cartoon. See how thin it is there? So you can imagine if you really thin that pars area by the laminectomy, it becomes weak and it can fracture. So this is like optimal, but if you do it this wide, you don't decompress the neurological elements. So you have to undercut. So this is what probably happens more often, and you can break through there. So just a couple things of spondylolisthesis following decompression of the spine. So this is an article from Neurosurgical Focus from 2015 where they reviewed 24 studies, like 2,500 patients, and this was a study to evaluate spondylolisthesis after decompression. So they had many different types of decompression, open laminectomy, minimally invasive, and they found post-op instability for decompressions was 5.5%. If you had spondylolisthesis and you just had a decompression, there's a 12% chance to get spondylolisthesis. If you had an open laminectomy, 12% chance spondylolisthesis. The reoperation rate for these decompressions was 2%. And the reoperation for pre-op spondylolisthesis is 9%. So basically, the people who get post-op spondylolisthesis for decompression only are full open laminectomies and people who already have some level of spondylolisthesis. So these are just the different types of spondylolisthesis. There's dysplastic, isthmic, degenerative, traumatic, pathogenic, iatrogenic, things that can cause spondylolisthesis. And this is a different classification. I won't get into it, but it's more for children. But it's more for dysplastic spondylolisthesis. So this is a spondylolisthesis when the bones are deformed. And you can see, show the pars, it's elongated there on the other side. See, it's elongated pars. So this happens more often in kids. But I'm not going to focus on that. Good morning. Oh, no problem. We're discussing iatrogenic spondylolisthesis in an 86-year-old man. So this is a cut of a bone in an animal that was ex-fixed, and then to show callus formation. So what does anybody? Can anybody tell me what callus formation is? Hmm? It's bone formation from a fracture. Okay, so the cut is a fracture, and Aaron, show them the callus. See how the bone forms in like a wad? So that's the way bones heal fracture. Now the reason why I'm telling you this is because today's topic is a Parse fracture. So a Parse fracture develops this, but you don't think about that because most people, orthopedic surgeons, think a callus that comes from a femur fracture. But the spine does the same thing. So when a spine heals, it heals with callus too, and I'll show you why that's relevant. So when a bone heals, it heals with callus. And this is just a cartoon. When a bone breaks, there's hematoma, there's inflammation. The periosteum elevates. Here I'm showing the periosteum elevates. It lays down cartilage, and this is part of the bone formation. So if you look at the histology, the bone is an immature woven type bone, and it even looks like cancer if you look at it carefully, but it's not cancer. It's just hypertrophic bone. And if a bone doesn't heal, sometimes you can get this, which is a hypertrophic non-union. You see how it's really big and expansile? So I know we're not talking about fractures today, but this patient has a Parse fracture. So the Parse fracture is a Scotty dog. Show him the Parse fracture. You get a fracture. And what happens is these fractures they don't heal unless you're a child. But in adults, they don't heal. Because of the motion involved, they go on to non-union. And what happens with the non-union? They lay down a lot of callus and bone, and they pinch the nerve as it exits the foramen. So you can see that as an artist's depiction. So you've got this fracture in your spine, which is very difficult to see. Remember, we couldn't see it on the MRI. We couldn't even see it on the CAT scan. And at a microscopic level, it's laying down bone and it's digging into the nerve root. So the problem is clinically is you have these patients come and everything's normal, and they say my leg hurts, and this surgeon says nothing's wrong with you. All the studies are negative. But if you understand the disease process, you know in your mind that's what's going on, is that patient has a Parse fracture compressing the nerve. And this is just what it looks like intra-op. Those are the pedicle screws, and the nerve, that's what it looks like intraoperatively, and it hugs the pedicle and goes out laterally. So just why that picture, Aaron, should be seared in your mind. So it's like during the surgery when we're decompressing the nerve roots, I'm sure you're thinking, what are you doing? You're like, where are you? What? So what I'm doing is I'm trying to create this because I know that's where the nerve is. That's what it should look like. So what I'm doing is I keep digging away at the scar and everything to find the nerve. So you have to know what it's supposed to look like. So this is just another interesting example that the surgery we did yesterday. And this is a 45-year-old man who had left sciatica. He had an L5 S1 decompression, and he had persistent sciatica pain. His surgeon performed x-rays, MRI scans, everything was normal, told him he doesn't need surgery, he just needs pain management. He went to multiple spine surgeons, had 2 ACDFs for some cervical stenosis. They felt that may help his leg pain. It didn't help. Everything was normal. I ordered a CAT scan, and this is the only abnormality he had in all of his studies, that little black line. So basically, he had a fracture. Like the decompression weakened his pars as a facet, and he fractured it. And what happened is, when intra-op, when we looked at it, we saw that it was a fracture, and then we saw that callus just digging into the nerve root. But there's no way to image that. There's no way to know that. You have to just know that as an experienced physician. So as a surgeon, we usually don't use our brain. So this is why it's like a big deal for me, because usually we just go by protocol and just images. But like medical doctors, they always use their brain. So this is also one more article about. I'm sure Dave is thinking, why are you doing surgery on an 86-year-old? I'm sure you're thinking of that. And this is a study that just was in 2015. The effectiveness of spinal surgery for lumbar stenosis and spondylolisthesis in the octogenarian population. And basically in this study, it showed that the results are very similar for over 80 and less than 80. The only caveat from this study was that the surgeons were a lot less likely to perform surgery on people over 80 for obvious reasons, because of risks, more bad morbidity, mortality. In this study, yeah, and I mean, dural tear incidence was 10% and less than 80, 14% and greater than 80. And I mean, the risks were the same. Patients did about the same, and the results were very good. Like, the most important one here is the one that's in yellow. The people were 60% satisfied if they had surgery versus 30% satisfied if they didn't have surgery. So surgery helped these people. Okay, so what do we do with our guy? Anybody have any suggestions? Oh, thanks. That's very kind of you. Oh, okay. So what should we do for this guy? Aaron, you're the only spine surgeon here. So you got to open up those foramens really widely, and then why do you have to fuse it? Yeah, so there's no way this is going to work without a fusion, and it has to be instrumented too, because once you open that thing up widely, it's going to want to collapse again. So you have to instrument it to keep everything still and open. I mean, I'm not. That may not be true. People do fuse. Um, that data actually is relooked at now. That instrumentation, there's new studies out now that show that non-instrumented fusions do very well. I mean, no offense, Brian and Tony, but that's another article we can go over. But I don't think I'm not 100% sure, but I don't think bone quality affects bone healing. So okay, so yeah, so this person underwent. You can see in yellow the nerve roots. We had to remove all that, the whole pars, the whole lamina, everything to fully open up the facet, and it was a mess. It was it was fractures, it was healing callus, everything had to be removed. And you can imagine once you remove all that, it will collapse even worse. So the X's are the screws. We instrumented it and fused it, and the case went reasonably well considering it was a big revision. 4 hours, 200 cc's blood loss, 2.5 liters of IV fluid. So it was not that big of an insult, I think. What do you think, David? Insult like this? 4 hours, 2 liters in. How would you grade that?
I agree. You have to do what you have to do.
Yeah, but still, you don't want to do. Let me tell you what's in my mind.
I'm not really qualified to.
I know, I'm just horsing around, just talking to you. But let me tell you what's in my mind is that you got to do a surgery for somebody. If it's an 8-hour surgery, I don't think I'm going to do it. If it loses 2 liters, I'm not going to do it. I mean, it's the right thing to do, but I'm not doing it. I'd probably send it to university or Hopkins or somewhere else because I think it's extremely high risk for medical complication. Mm-hmm. But I think 4 hours, 3 to 4 hours, and 200 cc's blood loss is easily tolerated. So those are the things that go through my mind. And this case could easily be a 6-hour case if it doesn't go well. So, yeah, you could easily lose in a revision lumbar fusion. You could easily lose 1 or 2 liters if things don't go well, or if the patient bleeds. You know, some people have a natural predisposition to bleed. So this is him 2 weeks post-op, and you can see I opened. He's a little bit straighter through the instrumentation and through a table. So I opened up his frame and fused him. His lateral looks pretty much the same. I didn't try to reduce it, but his leg pain was completely gone. And at 2 weeks, he was already extremely happy with the surgery. He said, you know, I'm hurting, but my leg pain's gone, which is, you know, extraordinarily thankful. He can walk without pain. He's in a walker. He'll probably lose that walker. He'll probably go to a cane in the next month or so. So that's it. That's a quick conference. So any questions about Iatrogenic spondylolisthesis, Parse fractures.
I read your paper. I read it. It's not.
Oh, good.
I'm
Was
going
it?
to iPad.
It was a nice review
Yeah,
article.
it was a nice readable.
Yeah, on the topic. I thought it was very readable. Yeah. So any questions at all? Anyone curious to any questions? Yeah. Yeah. Back where I took it from. Why not use allograft? It's better. So people's own bone, the ilium, iliac crest, is much better than allograft bone. The difference is bone. When you fuse people, there's three components that you need for bones to fuse. One is the hormone bone morphogenic protein. The second is cells, like actual cells, osteoprogenitor cells. It could be osteoprogenitor cells. You can get cells also from muscles sometimes too. And the third is a scaffold, which is the calcium hydroxyapatite. So when you have cancellous allograft cubes, all it is calcium hydroxyapatite. Because what they do is they take dead people, they cut their bones up, and then they wash it out completely. They zap it with irradiation. So there's nothing living in that allograft. There's no cells and there's no hormones, BMP. All there is a scaffold. So that's not as good as iliac crest, which has all three. Now, the ilium it's not a moving segment. So that fills in with bone very easily and it looks totally normal in 2 years. So if Brian's the one who told me to do this. He wanted me to use this product, but then I just used allograft. But the industry told me to do this to use their product to backfill. But it works incredible. So Aaron and I, we've done. Remember, we went back on a patient 2 years later, and that looked like a normal ilium, and we used it again. So what happens is that the body invades with cells from the pelvis and reincorporates that allograft, lays down its own bone because of the constant remodeling, and then the ilium is normal. So people probably don't believe me, but they always say bone graft hurts worse at surgery. After a bone graft, you always hurt. Tell people when we do bone grafts, what do they say? Right. So the typical the way I was trained was you strip all the muscles off the ilium. I don't do that. And then you take an osteotome and you cut strips and remove the outer cortex and the middle table. So you're left with only the inner table. So what happens is the bone is a lot weaker. It's deformed, which I'm not sure if that's going to cause pain. But the other problem is that the muscle of your buttocks, your gluteus medius, has been stripped, and it's painful. That's where the pain comes from. So the way I do it is basically just a tiny hole, and I don't strip any of the muscles. So I think the pain comes from the buttocks. Every time you move your leg, your buttocks fires. Yeah. It's a much more morbid process. So you lose the structure. Yeah, the ilium has changed forever. Yeah. So I'm not sure why anybody would ever do that. And that's how everyone used to do it. I'm not sure how many people do it my way. You never heard? People know about it though. I mean, you do it with minimally invasive approaches. People do it. I don't know. People just don't even do bone graft anymore. They just use products. Right, right. There's some evidence that aspirating, you get the cells, and allograft is sufficient. But basically, if I'm going to do it, I'm going to do it right. That's kind of like my personality. So I do the best thing, which is iliac crest. Maybe it's overkill, but that's how I do it. I have a very low, yeah. I can't remember. Yeah, I can't remember. We may have used BMP just to save time because it was a high risk case. Dave, what were you going to say?
I had a question.
Yeah. We're done. Go ahead.
I don't recall what anatomically what far lateral recess.
Oh, that's outside of the frame and far. It's rare. On the outside of the frame and far, the discs can herniate and hit the nerve coming up from above. So it's where the disc is herniated. So it can be herniated in the middle, It can be herniated in the foramen, in the hole where nerve exits, or outside of the foramen, hitting the nerve in the pelvis.
Oh,
So a disc can herniate anywhere, like 360 degrees. The disc is a circle. It can herniate any in that 360-degree area. If it herniates in the front, there's nothing there. It's like there's abdomen, like
oh,
retroperitoneal space. It just tells you where the disc herniates. It's
mhm.
rare. I have a lecture on that actually at YouTube. I'll send it to you.
Oh,
Far lateral disc herniations.
oh.
Explains it. Yeah. Yeah. It's like Wiltse approach. It's lateral.
And then he made a statement here about surgery, which really confused me. Once this exposure has been accomplished, slow medial dissection can begin from the lateral aspect of the facet joint to the edge of the bone resection from the prior laminectomy.
Yeah. Yeah.
Lost me there.
I'll show you. I'll show you. So basically, when you do these revisions, hold on. So you do these revisions. Let's say you're going to show the posterior elements. So on the right side. Here, let me do this. So this is all that's left of the bone here. You start on the bone and you go to the junction of the scar and the bone, and then you start decompressing. So you go from lateral to medial. So you have to find this bone, and this scar and thecal sac is a mess. It's very difficult to know what's scar and what's nerve. And you don't want to tear the nerve. It's a disaster.
Right.
So that's how. So the way you do it is you start on the bone, and then you creep, and then you take a small curved curette. I use a small curved curette, and I find the junction of the scar and the bone, and then I just dig, keep removing the bone, and then find dura, and then lift the scar off the dura. So that's just how you do it.
I see. Yeah.
Okay. So what else? Any other questions, Danielle? You come on. You're an inquisitive girl. Yeah.
Another one about the study. I would like to know your idea or your thoughts on his numbers, because he's saying, look, my numbers are really great, and the success rate of that at the beginning of the paper it says the success rate of this surgery is only about 60%. That's not a great success rate.
No.
And then at the end of the paper it says, well, my result, I get about 90% improvement. So
Well, I think when you look at these numbers, what are you going to do with these people? I mean, if you don't do a surgery, the other option is pain for life.
I see that. I see that.
And that's
Yeah.
not good either. So, what other options are there? Opium doesn't work long term.
Right.
I mean, I don't know what you all. Yeah, it does, and it also just doesn't work. It's just like alcohol. Like, alcohol. If you drink a 12-pack every day, you're never drunk. It just doesn't work. So opium, I feel, doesn't work either. And when I see these people on long-term opium, they're miserable. They still have pain. They don't feel any better. They just need to get the baseline with their opium intake. And then they have all the problems of opium, yeah. So, I mean, some of these people, they have no choice. Like this poor guy, he's like, he goes, I can't live like this. And I told him, look, you may die from this surgery. You understand there's a mortality risk. In other words, you may not survive. He goes, so be it. He goes, I can't live like this. I'm willing to roll the dice. And I thought it wasn't going to happen. If they think they're going to die, I'm not doing the surgery. But I'm just saying there's a chance. And he said, I'm willing to take that chance. I just can't live like this. Keep deteriorating. Right. They deteriorate very quickly, yeah. Right. The fact that he walks into the office and says that he'll get better. I mean, the fact that he's still walking, but if you don't fix it, he's going to stop walking. Yeah. They deteriorate very, very quickly. They become wheelchair dependent. Yeah. Daniel, you've got to have some kind of question. Come on. Nothing? All right, you're being quiet. Any other questions, Aaron? Any other questions? Anybody have any questions or thoughts? Please, please. What is it?
When you say,
Does everyone know our new spine coordinator? Did you know that? She's our new spine coordinator at Upper Chesapeake. She's going to help patients, Kirsten, she's going to help patients before and after surgery and help them with the process and go to rehab and place, right, everything. Understand the surgery. Yeah. So, Kristen, sorry. So what, go ahead. What were you going to say?
so the fusion with instrumentation. I thought fusion, when you're doing a fusion, I thought it's still, and then,
Yeah.
or the, because unless the actual, the instrumentation is actually just the screws going in, and then the fusion.
Let me tell you how I say to patients. Let me tell you how I say to patients. The screws, all they do is hold things still. The fusion actually takes from putting bone there and shaving the bone down to make a fracture type environment. So if you shave the bone and put bone there, it's going to fuse still. It's still going to fuse. You don't need the screws to fuse. The screws just increase the chances of it fusing because it holds it still. You understand?
Yeah.
So you don't really need the screws. I mean, Brian will tell you need them, but you don't really need them. Like, you can still fuse. It's just better with the screws. Yeah, the screws will break eventually from motion. Yeah. So it just holds things still basically until the bones heal.
So like for instance, when you're doing the
Mhm.
if it's just like an ACDF, then you have or is it
Everybody,
ACDF?
for ACDFs, everybody puts plate and screws now. So it's almost always. In the old days, people did it without plate and screws, but everyone does it now. Yeah, uncommon. Yeah, uncommonly. Yeah, I do sometimes, not too often though. I usually use screws. Yeah.
And how does that change?
I don't do. I stopped all precautions. I let people do whatever they want. I just figured
When
just.
you have instruments that are not.
My opinion is people are going to do what they want to do, and I also want people just to get moving. So I don't want people to be worried about moving. So I want people to get back to their lives, and I want them to be as active as possible. So I don't even restrict anybody, unless it's a kid. Like an 18-year-old kid's crazy, you got to tell them to calm down. But most adults, they're they're reasonable. Like an 18-year-old try to play basketball like 2 days after an ACDF. So you have to 18-year-olds, you have to give precautions, but adults usually they don't need precautions. I mean, that's my opinion. It's controversial. It's been studied a little bit too, like discectomies. Like they studied like people who had precautions, people who had no precautions, and there was no difference. So it's probably not necessary. What else? Any other questions? Anybody? All right. Thanks for coming. See you next month.